Hi, everyone, and welcome to Improving Breast Cancer Outcomes in Communities of Color, Steps Towards Equity. We're going to start the program in another 2 minutes to let people who have registered sign on. Hello, and welcome to Improving Breast Cancer Outcomes in Community of Color, Steps Towards Equity. I'm Danielle Andrews, the Program Manager at SHARE. Before the presentation begins, I'd like to tell you a bit about SHARE. SHARE is a national nonprofit that improves the lives of women affected by breast or ovarian cancer through experienced peer support, accessible education, and innovative outreach, always for free. It meets women wherever they are, and especially in medically underserved communities, with the insight of women who have been there too, creating a nationwide network where women are empowered and feel less alone. SHARE's free services include support include support groups, educational tools, expert-led webinars, presentations, a national helpline, online communities, and survivor patient navigation. For more information, visit our website, sharecancersupport.org. All participants will be muted during the presentation. When the presenter finishes speaking, we will open up for a question and answer session. You are welcome to submit questions during the presentation through the question pane in the control panel on your screen. When asking questions, remember the presenter is unable to give specific medical advice, so please keep your questions general in nature. The webinar is being recorded and will be available on the Share website soon. Dr. Hayley Thompson is an associate professor of the Department of Oncology at Wayne State University School of Medicine. She is also Associate Center Director of Community Outreach and Engagement at the Karmanos Cancer Institute. Dr. Thompson's research seeks to understand and eliminate racial and ethnic disparities in cancer prevention and control. Specifically, her research focuses on social-cultural factors that impact cancer screening. Additionally, she is the creator of the Group-Based Medical Mistrust Scale, and her research experiences also includes the development of culturally targeted interventions. Further, Dr. Thompson is currently Project Director of the Witness Project of Detroit, a faith-based breast cancer education and outreach program. Without further ado, I would like to welcome Dr. Thompson.
Thank you, Danielle, for that introduction, and I hope that everyone can hear me okay. I'm really happy to be here with you all this afternoon, and I want to thank Cher for inviting me to present today. So today, I'm going to be talking about breast cancer outcomes and improving them in communities of color, steps towards equity. Okay. And I just want to review the objectives for today's presentation. First, I'm going to review racial and ethnic disparities in breast cancer outcomes. And then I want to spend some time really defining and framing the problem of disparities in terms of health equity. And really, that is a lot of what I want to and I hope to accomplish today, is really to broaden our understanding of disparities and equity, in hopes that it will, make us, myself included, more responsive and innovative in the strategies that we use to eliminate disparities. I think we need to really understand and fully and define the problem well if we're going to be able to tackle it. And then I'm going to spend some time discussing potential solutions and approaches. Okay, so first let me give a pretty traditional definition of cancer health disparities or cancer disparities. And this is one that is currently used by the National Cancer Institute, which is part of our National Institutes of Health. And they define cancer health disparities as adverse differences between certain population groups in cancer measures. So what are those measures? They include incidence, so that those are our rates of new cancers, usually in a given year. Prevalence, which are the rates of all existing cancers. Morbidity, which has to do with cancer severity. Mortality, cancer deaths. Survivorship, so that's sort of longevity after cancer diagnosis, and quality of life, well-being after cancer treatment. Disparities can also include differences in the burden of cancer and related health conditions or comorbidities, screening rates, and stage at diagnosis. So I'm going to just do a brief overview of what are the major disparities when it comes to breast cancer in the United States. So I just want to share some graphics. A lot of this comes from certainly the National Cancer Institute, our SEER registries, and the American Cancer Society. So incidence rates of cancer, when we look across racial and ethnic groups for breast cancer, and many of you probably know this, white women in the United States have higher incidence rates. So there are more new cancers among white women in a given year compared to women of other racial and ethnic groups. However, you just move a little bit past this and think about, okay, so these represent new diagnoses. What about the stage of diagnosis? So here you can see some trends in terms of stage of diagnosis across race and ethnicity. If you look at the upper left graph that represents non-Hispanic white women, you can see that that top line represents localized or early stage breast cancer. And if you compare that top line to the top lines of the other graphs, it's a lot higher, which means that white women are more likely to have their breast cancer diagnosed at an early stage when it's more treatable versus women of other racial and ethnic groups. So this is where we start seeing some disparities. And now let's look at mortality. So these represent death from breast cancer. And here we see some of these, the bar graph flipped. So whereas white women had a higher incidence of breast cancer, non-Hispanic Black women are more likely to die of it, even though they're not diagnosed as often. So again, this represents yet another disparity across race and ethnicity. I also want to share survival rates. So survival represents how many women are alive 5 years later after a diagnosis of breast cancer. And you can see if you look at the bars, the purple and gray bar all the way to the right, with the purple representing Black women and the gray representing white women, the percentage of women, Black women, alive after 5 years after diagnosis is lower than the percentage of white women. And that's across all stages. So again, yet another disparity here. So what I've talked about in terms of incidence, stage of diagnosis, mortality, survival, are often some of the really major outcomes that get a lot of attention. But there are other outcomes that we need to pay attention to as well when you think about the cancer experience as a whole. And I find that a very useful way of talking about other types of outcomes across the cancer experience is using a model called the cancer care continuum. And again, some of you may be familiar with this. I always really think this is always really useful to me as a researcher and as I do presentations and teaching other people about disparities in cancer care. So this cancer care continuum represents all the different phases of cancer care and is really useful when we think about disparities because they represent a continuum of care and places where really people can fall between the cracks in the process of getting care. So it starts all the way at the left with risk assessment and management, which can include genetic counseling and testing. It can be risk assessment in terms of lifestyle factors like smoking or physical activity. It can include primary prevention, such as smoking cessation, so quitting smoking. Detection for breast cancer includes mammograms and clinical breast exams. Diagnosis has to do with biopsies and imaging to kind of confirm a cancer diagnosis. Treatment, and then even after treatment, recurrent surveillance. So that means monitoring for the recurrence of the cancer or monitoring for new cancers, and also end-of-life care. So along this continuum, I just want to share with you some additional disparities that are important along some of these dimensions. So risk assessment and management, studies show that African American women are less likely to participate in BRCA counseling and testing. So that's counseling and testing related to BRCA mutations that it can increase the risk of breast and ovarian cancer. African American women are less likely to participate in that compared to white women. In terms of detection, national statistics show us that Latinas aged 40 years and older are less likely to report a mammogram or having a mammogram in the past 2 years compared to white and African American women. In terms of cancer treatment, this is some very interesting work that has spawned a lot of some more recent research to kind of address this problem. African Americans and Latina breast cancer patients are less likely to receive adjuvant therapy, such as chemotherapy or radiation therapy, compared to white breast cancer patients, or receive lower dose or lower intensity adjuvant treatment. And then in terms of recurrent surveillance, African American and Latina survivors after treatment are less likely to be adherent to guideline surveillance. So after breast cancer treatment, it's recommended that a survivor have at least 1 to 2 mammograms a year, participate in a more frequent schedule of physical examinations, and these guidelines are less likely to be followed by African American and Latina survivors compared to white survivors. So again, just some additional examples of disparities related to breast cancer care and outcomes. So I think it's important to then think about, okay, how do we, if these are the disparities that we want to address, how can we frame them? How can we frame them in ways that are effective for intervention? So first, how do we make sense of these disparities? Well, and what are the causes? Some of the causes are genetic or biological. So we know that African American women are more likely to be diagnosed with triple negative breast cancer, which is a more aggressive form of the disease. Latinas are more likely to be diagnosed with larger tumors that are hormone receptor negative, again, so presenting a different kind of challenge for treatment. However, studies show that these factors, genetic and biological factors, do not fully explain disparities. We know that disparities in breast cancer death and mortality remain even when we adjust for some of these genetic or biological factors. So if that's the case, then we need to also be thinking about not only these more internal, again, genetic or biological factors, but also external factors as well. And definitions of disparities have evolved over time to acknowledge that, these more social or external forces that affect outcomes. So remember the first definition I gave you from the NCI talked about adverse differences, right? But now, in more recent years, this definition or other organizations have revised this definition to kind of to acknowledge kind of the social dimensions of disparities. CDC defines health disparities as preventable differences in the burden of disease and injury and violence, or in opportunities to achieve optimal health experienced by socially disadvantaged racial, ethnic, and other population groups and communities. Okay, so again, acknowledging social factors and the differences between different people, and the social experiences of different people and different groups in disparities. And I think a very pretty comprehensive definition of disparities comes from Healthy People 2020 in Health and Human Services. And they define a health disparity as a health difference that is closely linked with social, economic, and or environmental disadvantage. And health disparities adversely affect groups of people who have systematically experienced greater obstacle to health based on, again, their group status or some characteristic that is historically linked to discrimination or exclusion. So when we think about systematic, experiences related to obstacles to health, when we think about discrimination exclusion, this really moves us into an area of fairness and justice. And I think that is where that brings us more solidly into the idea of health equity and health inequities. And how do we define health inequity? Differences in health that are not only unnecessary and avoidable, but are unfair and unjust. And due to differences in the distribution or allocation of a resource or resources between groups. So again, we've seen this evolution of the definition of disparities and a movement towards a discussion of equity and inequity, because there's a growing recognition that health and breast cancer and breast cancer outcomes are not only determined by individual level factors such as genetics and biology, or even an individual's behavior and their medical decisions and choices, but it's determined by broader social, societal levels or social determinants. And that's a term that a lot of you probably have heard, the social determinants of health. It's really important to think about when it comes to breast cancer disparities, and it's really essential that we think about it when we are devising and developing and implementing interventions or strategies to reduce or eliminate disparities. How we define the problem is going to influence how we approach the problem. So let me talk a little bit about the social determinants and the ways that we often talk about social determinants. So often we use this metaphor of a river, kind of upstream and downstream. We talk about downstream determinants and upstream determinants. So if you think about, you have a river, and downstream is where maybe you collect the water to drink, and maybe you can't drink that water, it's not drinkable. And perhaps because downstream we have debris or mud that makes it undrinkable. When you think about that metaphor of a river, it's, oftentimes it's because that mud or debris is it's flowing down from upstream, right? And maybe upstream there are things happening that we don't see or we're not even really aware of, or difficult to kind of determine, such as, maybe there's high winds or there's a storm going on more upstream, and that's affecting what's happening downstream. Well, that's the way we can think about determinants of health. So downstream is what we can see and sort of closer to the problem, right? So it's closer in terms of time and space. So examples of downstream determinants when it comes to health and cancer specifically, biological and genetic factors, maybe behaviors, psychological factors like our mood or attitudes. These are things that seem to be proximal or really close to a health outcome, such as late diagnosis of cancer. And it's expressed on that more on that individual level, right? But again, what's happening downstream is probably being affected by things upstream, right? And something happening that may be a little less difficult to parse out, a little more difficult to parse out, I should say. So upstream determinants, they're kind of these fundamental causes that are a little bit more distant, but they really are what's setting into motion these pathways or causal pathways that lead to health effects through the downstream factors. Okay, so if upstream determinants or social determinants and downstream social determinants. And one useful model of thinking about upstream versus downstream is something that is a model that many researchers and public health professionals use, called the Social-Ecological Model, right? And it's a framework for understanding how upstream factors shape the downstream factors. And what's really nice about and important about this model is that it acknowledges that there are different levels of influence on health. And we'll talk a little bit about this, what these are, kind of from the societal level, working down to the individual, intrapersonal level. Even though we think of it upstream to downstream, they can affect each other. They're interrelated. They can be interrelated. So what are we talking about when we think about the societal level? That's that broad, maybe perhaps that broadest, highest level. It can include our history, ideologies, political structures, social hierarchies. At the public policy level, we're thinking about local, state, national, and global laws and policies. And that kind of moves down and can affect things on the community level, such as relationships between organizations and institutions, and even information networks within a defined boundary. You can also refer to our neighborhoods, and can include the physical and built environment. So what does our community or neighborhood look like? What are the commercial kind of the commercial organizations, or how many homes are in this community? How much green space is in that community, the physical or built environment. Community kind of affects institutions, our schools, our workplaces, characteristics of social institutions that have organizational characteristics and rules and regulations. Those institutions affect us on the interpersonal level, our relationships, our social networks, and our support systems. And that can include family members, co-workers, and friends. It can also include our healthcare providers. One institution that's important to, particularly in this context, are hospitals and cancer care settings. And that can affect the relationships we have with our oncologists or our doctors. And then the individual level. So we have all these things that can play a part on how we as individuals relate to health or make healthcare decisions. So these can affect our knowledge, our attitudes, behavior, and so on. So again, this is a very and an increasingly used model for thinking about disparities in health and disparities in cancer. So what I'd like to do is kind of really bring this point home in terms of the multiple levels of influence related to breast cancer outcomes and disparities. I really want to kind of bring that home by thinking about a specific societal factor and how and its relationship through these multiple levels of influence on breast cancer outcomes. And one that I think is relevant to many communities of color in the United States is racism. So I want to talk about some background and research connecting racism at all these different levels to breast cancer outcomes and disparities. So first, I just want to give a general definition of racism. And this comes from a really kind of landmark article by Kamara Jones, where she talked about the relationship between racism and health. And she defines institutionalized or societal racism as differential access to the goods, services, and opportunities of a society by race. It's institutional racism is normative, sometimes it's legalized, and often manifests as inherited disadvantage. It's structural, codified in our institutions of custom, practice, and law. So there doesn't need to be an identifiable perpetrator. So, oftentimes people think about racism as, maybe somebody calls you a name or does something unkind to you, but really it goes beyond that. It's evident in, it's more evident in systems throughout our society. And it manifests itself both in material conditions, so what we have access to, as well as access to in terms of resources, as well as access to power. Okay, so we're starting with that as kind of that outer and largest level of our social ecological model. So I want to say, how does this societal factor, this ideology, affect things on the level of policy? Well, okay, so public policy. So one way, and there are multiple ways, but I'm just going to focus on one, just one, has to do with a policy called Jim Crow. So some of you may be familiar with what that is. Jim Crow really is the legalization of racism, or a racial caste system that emerged during the period of emancipation. So that's the period after slavery in the United States and Reconstruction after the Civil War. So during so it basically is thought to have lasted from basically the 1870s all throughout the 1960s, and kind of was ended by the Civil Rights Act of 1964. So this really represented the idea of the races are separate but equal. Now we know they weren't really equal, but that was the ideology. But here, really, the focus was on separation. And I have some of these signs here that I have on the slide were very common during this period. So we had separate drinking fountains for white people versus people of color. We couldn't sit, colored served in the rear. We couldn't sit in the same places in restaurants, or sometimes we couldn't be served in some restaurants at all. We certainly sometimes couldn't live in the same apartment buildings or neighborhoods, right? So how does this affect breast cancer? Well, there's some interesting work that came out a couple of years ago related to Jim Crow as a public policy and breast cancer. And so what these researchers examined was where women who were born during the Jim Crow era, so born before 1965, because remember I said it was ended around 1964 by the Civil Rights Act. Where were these women born? And here on the map on the right, I have those red states represent the places where Jim Crow was dominant. Those Jim Crow laws were dominant. And their work looking at breast cancer and incidence incidence data showed that women, African-American women who were born before 1965 were more likely to have estrogen receptor negative breast cancer. Okay, and again, estrogen receptor negative breast cancer, where do we know that from? We know that from triple negative breast cancer, right? A more aggressive form of breast cancer that's more difficult to treat, right? And so they didn't observe this effect for African-American women born after 1965 or white women, regardless of whenever they were born. So again, so here we see some really compelling data showing the relationship between public policy and breast cancer disparities, or breast cancer outcomes. Okay, so let's go to the next level, right? Because the next level, how does then this public policy affect things on the community level? So if Jim Crow, as I mentioned, is the legislation of the separation of the races, so people don't live together. Let's go to segregation, or racial segregation. Right? Because again, this is directly following from Jim Crow, and we have this legacy of Jim Crow because we still live in a very highly segregated country. On the right, you see this map of the United States just showing some data on some of the most segregated areas in the United States, with the dark blue dots, the darkest blue dots representing the most segregated areas, and the lighter blue being less segregated. But again, this represents the physical separation of members of one racial group from those of another group. And in fact, as of 2010, about a third of African Americans reported to live in hyper-segregated areas. So again, is racial segregation related to breast cancer outcomes and disparities? Well, some data suggests it's actually a little bit more mixed than you might think. So, racial segregation of breast cancer. Some studies show that for women, African American women who live in more racially segregated areas, the rates of breast cancer mortality are higher, right? So, and why might that be? That might be because of maybe more segregated areas, particularly where there's more higher concentration of African Americans, maybe less resourced areas, maybe there's a different access or lower access to healthcare. Maybe they're poor areas and more stressed areas, and that stress is perhaps part of that pathway to breast cancer outcomes. But there are also some counterintuitive findings have been reported. And there's at least one study that shows that greater segregation was associated with lower breast cancer specific mortality. So that areas in which there were higher concentrations of African Americans and they were more segregated, the rates of mortality were actually lower. And that might be because perhaps living with people who are more like you, who look like you, or maybe are more like you culturally, might have a protective effect. They call it an enclave effect or an ethnic density effect. So there potentially is more work that can be done in the area. But again, we're seeing these links between, again, we've gone from the societal ideology of racism to public policy, Jim Crow, and then we move to actually the community level and segregation. So let's go to the next level. So you might think that, okay, if for folks, and we sometimes see this in our real lives, when we don't live or not exposed, we don't live with people of other groups, we're not exposed to people of other groups, we might have negative views of those other people or hold stereotypes about those people. So which can leads us to our next level, the interpersonal level, okay, racial discrimination. So I want to talk about racial discrimination in terms of one of the ways, and actually a very common way of measuring it, as in a multidimensional sense. So there's one popular measure of racial discrimination that looks at 2 dimensions. It looks at everyday discrimination. So that has to do with kind of chronic or ongoing kind of interpersonal discrimination that, is relatively minor. So, and more common given in a person's life. So some examples of the questions that people get asked related to everyday discrimination are, people act as if they think you're not intelligent, or people act as if they are better than you. And these are events that are, given the 2 dimensions, would occur more frequently. Then it also looks at major experiences of discrimination. So those are acute, major life events, like being treated unfairly due to race on your job, or when you're trying to get housing, or being treated unfairly by the police. So, is racial discrimination related to breast cancer and disparities in outcomes? I'm going to actually give you a few examples here. So, sorry, I'm having a little difficulty scrolling down. Oh, sorry about that. Okay, so racial discrimination in cancer. So in one longitudinal, so this is a cohort study following a large group of African-American women over time. African-American women in the study who were younger than 50, who reported higher everyday discrimination, again, that more chronic, ongoing discrimination, were more likely to develop and be diagnosed with breast cancer. And then African-American women who reported discrimination, the major events of discrimination across all 3 areas, police, housing, and job, were more likely to develop breast cancer than were women who did not report any discrimination in any domain. Okay, so again, we're seeing this link between discrimination and breast cancer progression. But so I want to share another study with you because this when you measure discrimination in this way, you're really looking at kind of a more it's subjective, right? It's a person's perception of the discrimination that they experience. So what happens when you look at something in a more objective way, right? So this next study is not specific to breast cancer, it's more general, but I just want to share it because it really to me, it's mind-blowing. So when we look at area level racism as a proxy for racial discrimination, okay, so this one researcher, David Che, took a look and he was able to work with Google, right, and get data on Google searches in different areas of the country, searches that included the N-word. N-word being a derogatory term that used for African Americans. His research found that in areas where there were there was a greater proportion of racist searches using the N-word, in those areas there was greater cancer-specific mortality among African Americans. Right. So again, this is just another example and a kind of pretty powerful example of the relationship between discrimination, racism, and disparities that we see that negatively affect African Americans. And I should just mention also that I'm focusing on African Americans today because there's more data on African Americans. But again, given some of the similarities and experiences of people of color in the United States, it's not. It wouldn't be odd to think that, or stretch to think that this would also might be the case for other people of color and communities of color. I want to share another study with you. related to racial discrimination that's actually done by one of my, was conducted by one of my colleagues here at Wayne State University and here in Detroit. And he's a social psychologist who looks at implicit bias. So that has kind of like the unconscious racism that people hold, right? But we are able to measure it. And his work focused on African-American cancer patients and their interactions with their oncologists. And he had oncologists take something called the IAT. So and it's a measure of this implicit bias. How much unconscious bias do you have towards members of a particular group? And he found, and this was a study that was only conducted with African-American cancer patients and their oncologists. And even though it was a mix of cancer patients, the vast majority were breast cancer patients. And he found that oncologists who demonstrated higher implicit bias actually had shorter interactions with patients. And then the patients themselves rated the communication by these oncologists as less patient-centered and supportive. And I should also add that these interactions were video recorded. So, and then they had independent observers look at the videotapes, and they also rated the oncologist communication, those had higher implicit bias, as less patient-centered and supportive. And moreover, furthermore, oncologist implicit bias was associated with less patient confidence in recommended treatments. And we're talking about people's cancer treatments. And I should also mention that these were newly diagnosed cancer patients who were making treatment decisions, and also was associated with greater perceived difficulty in completing recommended treatments. Okay. And this is important and a nice study to transition with, because, you know, whereas the other work I described talked about the relationship between racism and discrimination or public policy and the outcomes like, you know, mortality and incidence, this really starts to talk about other parts of the cancer care continuum, right? What is the pathway, you know, between some of these higher levels of the upstream levels of influence and the downstream level of influence, right? So now we're seeing some things play out through patient-doctor communication and patient-doctor interactions. What are some other pathways that might exist? We can think about, you know, lower access to care and supportive services. We can think about cultural norms resulting from racism that have a defensive function. So people may start to not trust medical systems, or they avoid cancer care because, you know, the discrimination that they may face in those settings. Or they may want to avoid settings where they can't see a provider who's the same race or the same background or speaks the same language. We can think about kind of behavioral pathways, you know, so there's studies showing that, you know, a relationship among African Americans between smoking and the stress of racism. Smoking helps to relieve the stress of racism, and certainly there are affective responses to racism like depression and anxiety that can play a role in people's perhaps delaying care. So again, I wanted to share this, kind of give you an example of how the social-ecological model can be used to really understand different ways and different pathways and different levels of influence on health outcomes. And here we're talking specifically about breast cancer outcomes. And again, it's important, I think, to understand these multiple levels of influence when we think about then how do we tackle disparities? You know, this is complex, you know, but we need to kind of think about, you know, these disparities and these issues holistically if we really want to kind of move the needle in terms of outcomes for diverse groups. So I kind of want to return to equity, right? Health equity means that everyone has a fair and just opportunity to be healthier. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and health care. You know, and I like this image here of equality versus equity. There, you know, more of these images are being shared to kind of show the difference, like what equity means. You know, it's not just giving everyone the same access to necessarily the same resources, but sometimes people need more. You know, sometimes people need tailored resources to meet their needs in order to have be more equitable in our care. So if there are multiple levels and factors that influence breast cancer outcomes, you know, we perhaps need to be looking at multi-level strategies to achieve equity. And, you know, as a researcher, I can say that multi-level strategies or multi-level interventions are are receiving a lot more attention. And there's a lot more funding, frankly, in going into developing multi-level strategies and more interest in kind of evaluating these strategies and approaches. And very simply, they are strategies that target multiple levels of influence when it comes to health. And they intervene at a number of levels, like based on that social-ecological model. They either deal with them simultaneously or in close succession, but they're complex, and it can be hard to understand how they are interrelated. Those synergistic effects between the levels can be hard to evaluate, but they're promising, and there's more work in some other types of cancers, such as cervical cancer, particularly work around HPV vaccination as a way of preventing cervical cancer. And there's also more work with colon cancer, colorectal cancer. There are fewer examples in breast cancer, but I wanted to share a couple of examples just to give you all a sense of the kind of work that's being done and kind of approaches we might think about taking. So this is a more recent study, a multi-level intervention to increase Latina participation in mammography screening. And this looked at two different levels of influence. It looked at the patient level, so that's the individual level, right? So how can we change an individual's behavior, and here we want to change behavior related to mammography. So they trained promotoras, community health workers, to complete or conduct some motivational interviewing, which is a particular approach to encouraging female patients at 4 community health centers, encouraging to obtain mammograms. But they didn't just do the promotora program, they also implemented a clinic level intervention. So all these clinics, the 4 clinics, offered mammography or offered mammograms, but they kind of enhanced or extended the services that these clinics provided by adding a mobile mammography. So that was a way of extending the reach of the clinics. So that's one example of a multi-level intervention. It focuses on different levels of the problem. One that's a little bit older, but I thought was really just a really ambitious and dynamic approach is this Boston Racial and Ethnic Approaches to Community Health, the REACH 2010 Breast and Cervical Cancer Coalition. So they began with building a coalition of key stakeholders, so that included public health professionals and officials, community health workers, social service providers, and advocates, right, to come together around increasing screening, specifically among Black women when it comes to breast and cervical cancer. Then they identified women in the community to serve as outreach leaders, and they actually built capacity among those women by through leadership training and providing them with more information about cancer, as well as training them in other areas. Then there was documentation and data collection. They conducted focus groups of women in the community so they can understand barriers to screening from the community perspective. And they also did work and surveyed healthcare institutions, right? So they wanted to understand, what were the barriers within clinics and within hospitals when it came to screening. And then they created a community action plan that, again, really focused on both institutional and I think community levels. So they proposed and implemented a case management strategy in primary care settings, kind of like patient navigation, basically, to support women in getting mammograms. They implemented cultural competence training for healthcare providers. They created a program or tried to develop a program to increase the pool of radiology technologists who were trained and competent in mammography screening, with a focus on training African-American women to fill those roles. And they also conducted a multi-phase public education campaign. So again, they were trying to address the problem both at least the institutional level of the clinic and hospitals and care, as well as on the community level through education. Now, in terms of the outcomes, we need a lot. Like I said, there are not many multi-level interventions related to breast cancer, at least that are published in the literature. And again, the outcomes are mixed, which is not to say that we should necessarily abandon the strategy, but that more work is needed. We need to do some more thinking about this. For the Latina mammography screening study that I talked about a moment ago, they found that the promotora intervention was effective, but the clinic-based strategy with the mobile mammography unit didn't necessarily do as much to increase screening. Here, with this Boston REACH study, they examined, they only evaluated, or they only published evaluations of the case management approach, which also was successful in increasing screening rates. So again, I think that we need to more work in this area and more data in this area. But again, these are multi-level interventions that are trying to not just focus on one level of the problem, but multiple levels of the problem. And again, hopefully I've demonstrated that, it's really, we need to kind of have that multi-level approach and perspective if we really want to, again, move the needle when it comes to disparities. So I just want to share some work from the Robert Wood Johnson Foundation, Key Steps to Advancing Health Equity. First, I discuss identifying important health disparities that are of concern to key stakeholders, especially those affected. So in our case, we also want to make sure we include advocates and patients and caregivers who breast cancer survivors and their caregivers, as well as breast cancer advocates. We want to identify social inequities and access to the resources and opportunities needed to be healthier that are likely to contribute to the health disparities. And the second box, we need to change policies, laws, systems, environments, and practices to eliminate inequities in the opportunities and resources needed to be as healthy as possible. So 1 and 2 are pretty broad, but they're really advocating, again, this multi-level approach. And then the third box, evaluate and monitor efforts using short-term and long-term measures. And 4, reassess strategies and plan next steps. So in closing, I just want to focus on this one, on actually box 1 a little bit, and just talk a little bit about some things that we're planning here in Detroit when it comes to just working with community members and community stakeholders, because this is an area that's very near and dear to my heart. Again, like I said, the first box said it's important to really involve affected key stakeholders. Community members can play a vital role and I think are critical, actually, and necessary when we think about multi-level interventions, developing them and implementing them. And certainly can ensure that our interventions are tailored to the local culture and the local environment. We need those voices at the table. So some of what we've done to kind of move that forward here in Detroit, I just want to share a program that we have here called Michigan Cancer HealthLink. It was formerly Detroit HealthLink for Equity in Cancer Care, but we've moved beyond the city and are going to other parts of Michigan as a state. And this model focuses, through this model, we've built these cancer action councils. And there are groups of cancer survivors, caregivers, and advocates who again want to do something about the problems they see related to cancer in their communities. So these cancer action councils are based either on neighborhood or area or population. So we have one on the east side of Detroit, that's the Connor Creek. We have one, the Western Wayne Family Health Center is it's in a primary care center in a city that's right outside of Detroit. We have one here at the Cancer Hospital. We have one in an organization called Access, which is in a city, Dearborn near Detroit, that it serves Arab American communities. We have the Dearborn has the largest concentration of Arab Americans versus any other city in the United States. So that Cancer Action Council includes all Arab American women, and almost all of them are breast cancer survivors. And then we have 2 Cancer Action Councils with a grassroots organization called LGBT Detroit. And we have new Cancer Action Councils, again, outside of Detroit in Wayne County. So we're working with about, around 80 community members across 9 councils. And what do we do with these councils? We do some capacity building. So we train them about and give them training around research and how to collaborate with researchers, and they complete a research-focused curriculum. We engage in evidence prioritization, which is just a fancy way of saying that we develop research priorities, and we do that through a number of interactive exercises, and we also develop research questions, and then we bring them together with academic investigators because we want them to form partnerships to move their research priorities and questions forward. So what we're planning to do and preparing to do is work with these Cancer Action Councils on disparities in African American cancer survivorship. And we're going to be working with them to refine a predictive model of quality of life among African American cancer survivors based on the Social-Ecological Model. So we're interested in the multiple levels of influence that affect survivors' outcomes. And so we want to work with the council to really help to understand and refine, okay, what of these different levels of influence are important when we think about survivorship outcomes among African Americans. We want to focus on stressors related to racial group membership and that result from interpersonal, institutionalized, and structural racism and adversity, not only in the US, but specifically in Detroit. And then when we develop that model with them, We want to test it in a large-scale study of 600 survivors, and then those results will guide targeted multi-level interventions to improve survivorship outcomes. So that's one way that we want to take, some of these ideas around equity and achieving equity. We want to implement them here to improve breast cancer outcomes. So that's it. Thank you very much.
All right, Dr. Thompson, thank you for the presentation. Now we will start our question and answer period. So the first question we have is, due to the large trust between the African American community and their local pastors, should the healthcare system look to involve churches to improve access to healthcare?
So the question is, should healthcare systems work with churches to increase access?
Because Absolutely. Of the,
yeah. I mean, so there are a couple of perspectives, and there are a couple of there are several reasons for that. I mean, one is kind of coming from the perspective of culture and the role that spirituality plays in the lives of many African Americans, and how the ways in which religiosity or spirituality affects healthcare decisions and attitudes about health. But because it is churches are community centers, so they make sense as a place to places to disseminate information, to implement interventions, and it's already there. I mean, there are many cancer centers or local collaboratives that address cancer and breast cancer specifically that include churches. So absolutely, I think that again, I really focus and think a lot about kind of readiness to partner. So I think that certainly public health agencies, academic institutions should be reaching out to churches and faith-based organizations to partner. And I think also along with that, I think that there's a need for churches and other organizations, a need for training about about kind of public health issues, cancer education. What are kind of the important elements of a partnership? There needs to be education about disparities, and again, what are kind of strategies and best practices for addressing disparities.
Okay, so the next question is, on a societal level, how can we build trust between the healthcare system and women of color, especially after things like the Tuskegee study, Law 116, that allowed for women of color to be sterile without their consent, and then like the use of Sarah Baartman's body, who died in 1812 but wasn't put to rest until 2002.
Yeah, so trust is a complicated issue. And again, a lot of my own work kind of things, I think a lot about medical mistrust. And there's not an easy answer to that, but I think we can, we need to think about it at different levels, right? I think we can think about different and multiple levels of influence when it comes to medical mistrust. And there's some air levels that might be kind of more straightforward to tackle than others. But when it comes to healthcare systems, to the extent that the trust or mistrust is based on race or group membership, that is one way to approach it. So I think that within healthcare systems, having physicians and providers and administrators and decision makers who reflect communities of color, who will represent communities of color, is critical, I think, in terms of building trust. I think that we need to we could be more creative and purposeful in the way we think about our community advisory boards, our patient family, advisory groups that are part of different hospitals, and really bringing them more into decision-making processes at hospitals. Sometimes I feel like these community advisory boards and patient advisory boards we have that are established are just it can be very passive and just very reactive when it comes to kind of just the practices and policies of a hospital. And I think we need to be a little bit more deliberate in including, again, patients and community stakeholders in creating policy and revising policy and again, some of the decisions that affect patient care and patient satisfaction. So I think those may be a couple of ways to address the issue. I think that, in terms of our the actual healthcare providers or those who are on the front line in terms of interacting with patients. There's a lot more that we can be doing in terms of supporting them and improving their interactions with patients who may not be of the same race or same ethnicity or same background. You know, I think it goes beyond cultural competence. I talked about that implicit bias. You know, and some medical schools are doing this, and some hospitals are doing this, really helping physicians and providers uncover and really have a greater awareness of their unconscious kind of racial biases, and having them, you know, do the work to challenge themselves and challenge those biases and stereotypes that they hold. So again, I don't have, you know, kind of a comprehensive answer, but I think it's possible, but I think it takes quite a large investment to do that.
Okay. So the next question is, within communities like African American communities and the Latino communities, there are stigmas and fears associated with cancer. There's a lot of things that people don't speak about because of the fears and the stigmas associated with it. How can we help create behavioral changes that will lead women to take more preventative measures with their cancer?
Well, you know, let's even talk about. I'll go to the kind of the case that that was just presented. You know, in terms of people not. You've mentioned like people not wanting to talk about their cancers. People, you know, have the stigma around cancer. You know, I think there are a number of ways, and there are a number of ways that stigma is being addressed through some interventions. You know, Danielle, you mentioned that I work with a breast cancer outreach program called the Witness Project, and that's a national program. And part of that program is that we work with breast cancer survivors who provide education for the community. And part of what they do is they tell their stories, right? So and by sharing their stories, they destigmatize the issue, right? They are trying to remove some of the secrecy around cancer. But, you know, we can think about it in some different ways, right? If we think about that social-ecological model, you know, that's one intervention that can help, you know, people and communities be more open about the cancer experience. But, you know, let's think about at the institutional level, let's think about in our schools, you know, can we be doing more to kind of educate, you know, younger people about cancer? Because they're certainly seeing it play out in their families with older family members and for people in their community. So, you know, that might be one way of destigmatizing the issue and bringing some more openness and some more education around it. You know, we just talked about churches. Churches are actually an excellent way to do that. There are more and more churches that not only have health ministries, there are churches that actually have cancer ministries, and that is that's a trend that that I see happening around the country. You know, so you know, there are different ways through our institutions and through our social networks that we can do that work. You know, whether it be through sharing our own sharing experience of cancer that we have, or working through our families and friends and social networks.
Okay, well, thank you. I would like to thank Dr. Thompson for an informative program, and thank you all for participating. Please take a moment to fill out the survey at the end of the webinar. It may take a few minutes for the survey to download. Before we go, I would just like to mention that we have Talk Meds Tuesday, where women living with metastatic breast cancer can call 1-844-ACT-SHARE and speak directly to a metastatic peer if you press 6 on Tuesday. Thank you again, and thank you, Dr. Thompson.
Thank you.